Good evening, everyone. Namaskar, Sat Shri Akal, Vanakkam, Namaskar, and a very, very warm welcome to yet another webinar by young infection control nurses. All the participants have been trained by us, and this is our humble, effort to give exposure to the young nurses to host webinars. Thank you so much for joining us. And today we have a very special guest from outside India, though she's of course she's an Indian, but she is right now in Canada, and it is very early morning there, but she is taking time. Before I even invite her to the session, just give me a minute to just talk about this initiative. And as I mentioned in every webinar, we are doing this in honor of Infection Prevention Week 2024. Signia Healthcare, that's my company, is doing this in collaboration with Nurse India. It's a company that I partner with, and they have got the technology platform dedicated exclusively for nurses, the first time that I know of in India, and I believe in what they are doing. That's why I'm partnering with them. So we are very happy to invest our time in giving opportunity to young people. And so far, the response has been fantastic, and the people have been joining in big numbers, and encouraging the young speakers appearing here. See, all the topics have been around infection prevention, and today we are talking about cleaning and disinfection and environmental hygiene. And then on 28th, we'll have prevention of CLAPSy. And the last one is in prevention of VAP. That we will take a different date because 31st October seems to be Diwali here. So we are just going to postpone it to 4th of November. That way we will be honoring all the 7 webinars that we have promised to hold. So this was Halle, who appeared first talking on non-ventilator hospital-acquired infection. Then we had Rakshida talking about all about extravasation. Then we had Raji, strategies to prevent infections in acute care settings. Then we had Ashwati talking about preventing surgical site infection. And today, ladies and gentlemen, we have yet another young nurse, Amandeep Kaur. Right now, she is, staying in Canada. She's going to talk about cleaning and disinfection, environmental hygiene. And then we have Blessy speaking about CLAPSy. And then last but not the least, it will be Feba talking about ventilator-associated pneumonia. So once again, a very, very warm welcome. And let me welcome Amandeep to come on the video. Hi, Aman. Very, very warm welcome. And you can start by a little bit tell about yourself to the team sitting here. Where were you in India and when did you go to Canada and how are things there? I know it's pretty cold, maybe. I don't know. Tell us a little bit about that and then you can get into the topic. Because this is one topic which I think most nurses or even ICNs are not very completely clued on because they have other priorities. But there is more and more evidence coming up that the cleaning, disinfection, and environmental hygiene has got very high connection with hospital acquired infection. And you are going to throw some light on that. So I will request all the participants, in case you have any comments or any questions during the session, you may please put it into the chat box. And once we finish, as usual, we will spend some time discussing about that. Till then, Aman, I'm going to stay off the audio and video management, and it is all over to you. So please tell us about yourself, and then you can share your presentation.
Thank you so much, ma'am, for the warm welcome. And good evening to folks from Canada. So it's 4-degree temperature here. And
Oh,
we are landing into cold.
pretty cold, yeah.
Yeah. So I'm going to start off with my introduction. My name is Amandeep Kaur, and I'm delighted here today to be a part of this presentation as a presenter. So as an RN in India, I have 6 year plus experience in the field of infection control and prevention team. So I was leading the infection control nurse as a in the northern part of India. So during my journey, I has mostly provided the training and education to the new nurses and train them to innovate the technologies, innovate the new practices developed by WHO and other healthcare agencies. So in my these professional journey, I was an educator, I was a nurse, I was a clinical practitioner among with my infection control team. So today we are going to discuss about cleaning and disinfection in depth so that we know what is the root cause for spreading infection among healthcare settings. Because when we know the root cause, then only we can treat the cause. So I'm going to start up with my presentation part for now. So this section is divided into two sub parts. First, we will gonna talk about cleaning and disinfection of handheld equipments, and second, in the second part, we're gonna talk about how we can reduce antimicrobial resistance by following environmental practices. So I'm gonna start up with the first part, cleaning and disinfection of handheld equipment. So objectives for this section is we're going to understand about the need of cleaning and disinfection, why it is required, then what all different chemical agents and their contact times, and also about the Spalding's classification.
You stopped sharing, looks like.
Yeah, just I'm checking whether it's okay. Okay.
So what you can do is start sharing on the screen on the left-hand side corner, there'll be arrow. So just click on those arrows to move forward. You can put it on slideshow now.
Yep, now it's working. So this is something we all are very well versed with this. I hope there are so many ICNs and some link nurses or nurses uh, present in the session. So if you can quickly put it in the chat box, what do you understand from the chain of transmission? Anything you know about it, so that the session could be a little bit interesting, and let's see how many people are awake like me. So anything you know about chain of transmission, just write 1 or 2 words, and then I will move forward.
Hello, my dear nurses, you can put some words into the chat box on chain of transmission. I'm
Anything you know about
looking
chain.
at my students. I'll catch you later that you are not writing anything in the chat box.
I can see
Coming
some.
up. Hmm?
Yep.
Portal of entry. We
Yeah.
have hygiene
res-
host, reservoir, media. Okay.
Anything quickly? No use of PP. Okay. Host
Infection.
infectious
Okay.
agent.
Portal of
Port-
exit.
So you know pretty much. Okay, let me jump into it. And so yeah, some of you have written. So it always starts from a pathogen. So pathogen could be any bacteria, virus, fungi, or parasite that done. So reservoir is a person, animal, soil, or water. So reservoir could be where the organism stays, grows, and multiplies. And then it needs some portal of exit, like we always say, use safety precaution. We had 2 years with COVID. So we all know why mask is mandatory now, why mask is important at such places. So it can spread by air, by droplets, or either by contact. So we need to be very cautious while dealing with such patients. So it could enter into the body through feces, bodily secretions, and coughing and sneezing. Then the mode of transmission mostly hands. As we know, there are reminders for hand hygiene at the entry and at the exit points. So this is just to reduce the transmission, break the chain. So it could be spread by direct contact, indirect contact, or through vectors. And then it enter into a new human or new reservoir person that that is called portal of entry. So it can enter either through the mouth, nose, eyes, and cuts in the skin. That's why we always say if you have any injury or open wound, make sure you cover it before you landing for the job. Then it finds a susceptible host. It could be an elderly person or an infant or anybody with an immunocompromised state or anyone who have low immunity. So these are the 6 components. We can break chain at any point. We can either remove the pathogen so that the chain could not be started with the all other components. And in case if we know there is a bacteria, we should avoid the spread. So how can we avoid the spread is through proper cleaning and disinfection of surfaces, medical equipment, surrounding areas, high touch surface areas. So I hope you know what all are the high touch surface areas. Anyone want to mention about any high touch surface area where we can break our chain of infection? Anybody from the group would like to write something about how
Anybody,
can
many bodies should be writing. They all know high touch, high touch surface areas. All of them are
yeah.
aware. They all have been trained. Okay, then it comes doorknobs, door handle, telephone, bedside rails, door windows. Okay.
trolleys, food trolley. Yeah. Yeah.
Keyboard,
Keyboards are the most important thing. Medical
mouse, yes.
spotlights, yep. Ventilators.
Good, good. Happy
As
to
I
see
can
my
see.
students giving answers. Very good.
Yep. That's how I can see you all are awake. Okay, so thank you for answering. Yeah, these are some high touch surface area which we usually see person who is doing cleaning, they ignore. Like they clean the whole surface, but they forget to clean the doorknob because that's the thing which is gonna touch multiple time by multiple people. So yeah, we need to educate the housekeeping team on that as well. They should understand what is the chain of infection and how does it spreads, because mostly though they are the people who are actively involved in cleaning and disinfection, but without proper education and training they do whatever they know from their fellow workers. So being an ICN, we should be actually actively train them at least once a week how this chain can be break and what all are the prompting factor which affects the cleaning and disinfection practices. You might have been noticed there are people who are using the same glove pair cleaning throughout the different patient areas. So we may never know which infection can transfer from one room to another room. So we need to educate them, change of the glove in between the cleaning practices. So these are the some key loopholes we need to educate. We need to make people aware about. Everybody think they know, but we just have to keep a check on the things, some key loopholes where we are lacking in terms of reducing the infection burden and promoting good and safe hygiene practices. So next is best practices in medical equipment cleaning. So there are some practices recommended. Use of proper disinfectant. So choose EPA approved disinfectant suitable for healthcare settings. They should be effective against wide range of pathogens. So this means that if I am going to use a the disinfectant agent, which is effective only against E. coli, will I be able to promote any other infection rates, or will I be able to reduce any other microbial agents? I don't think so. The answer would be no. If I have to choose any disinfectant, I need to check what all are the pathogens that comes under that particular disinfectant, what all the effective rates that particular pathogenic flora is having. If I'm using only one disinfectant for particular microorganism, that is not going to work. So I need to see what all EPA guidelines says, how it's going to be effective to reducing certain deadly microorganisms present in the hospital or healthcare settings. Then obviously we need to follow manufacturer guidelines. So always adhere to cleaning instruction provided by equipment manufacturer. So there are some, when we order from Amazon, we always get a leaflet that says how you can operate this equipment. Same like that from the medical equipment cleaning disinfectant, we always get a leaflet with the information that is what is the dilution, how much contact time is required, and how we can use, what all equipments we can use for the disinfection purpose. These guidelines are specifically designed to ensure that equipment's longevity and effectiveness. So yeah, there are two types of equipment we always use. Some are disposable, some are reusables. So both have the different protocols, different mechanisms. So disposable ones are single use, as we know. But the reusable one, how much time we need to give them for a contact in solution so that we can reuse them up to a specific time period. Implement cleaning schedule. Regular cleaning schedule help maintain consistency. High-touch surfaces and frequently used equipment may require more disinfection. So as we have already know what all are the high-touch surfaces, toilet, flush points, and then in the bathroom taps, the knobs. And then if we come into the desk, medication trolleys, stethoscope, because I don't think every time whosoever is using stethoscope clean it up properly. So we need to be aware about high touch surfaces, and with janitorial team or housekeeping team, they should have some labeled picture chart. They know, okay, so these are some high touch surfaces. We cannot ignore them at any cost. Then water line maintenance. Maintaining clean water line is crucial in dentistry and dialysis. Contaminated water can significantly impact patient care and lead to severe health issues. So here I want to jump into a little bit discussion from the participants as well. Why dentistry is always on the top, or dialysis always on the top in terms of water line maintenance? Why we always say that in dialysis there should not be any contamination of water, the RO water checks are required? What is the reason behind that?
Hello, can I?
Yep,
If
please.
if we are using a contaminated water or not a sterile water, then through our gums and all, microbes can enter and it can go up to the kidney, brain, and all vital organs also. So in dentistry, it is very much important. Similarly, dialysis also, because the blood is flowing throughout. So within a short period, it will be infection is circulated throughout the body.
Thank you, Dr. Jyoti Chaudhary. So yes, you're right. So dialysis and dentistry. So as we reflect back to the chain of infection, one is called portal of entry, another is called portal of exit. So obviously we all take food by mouth. So that's our portal of entry. If in dental procedures, there is a contamination of equipment, water cleaning, or water pipeline, so there are chances that it can transfer from mouth to the intestine and then it go all other vital organs. So that's why we need to clearly keep a check on water lines with engineering department, with maintenance team. Is the water quality is good? Is TDS okay? Is TDS is not going beyond the recommended limit? What is the RO water process? Is plant getting checked as per the policy, as per the hospital protocol? So yeah, that's why we need to keep a check on everything. ICN is not only dealing with pathogens, but yes, she has to do something else with the cleaning and disinfection protocol. Yeah. So some points to remember when performing cleaning and disinfection. So I hope you all have the dedicated checklist for your departments, for the patient rooms, for infected patient. So this is just a sample layout for your reference. So before jumping to checklist, I'll make sure some points we should know. Ensure thorough cleaning and disinfection of equipment. So thorough cleaning means there should not be any microorganism load present. So before cleaning, it's always recommended wash with the plain water so that whatever content is present there, whatever blood spillage is present there, that the debris part should be removed before it is sent for final cleaning or disinfection. So priority again is given here for high touch surfaces. Make sure to follow recommended time exposure, certain EPA disinfectant. Use of UV light. Nowadays here in Canada, we are using some UV light technologies to disinfect certain equipments. Allow air to completely dry. They have designated storage areas. Maybe you know the CSST department. So where we store according to the recommended requirement. It should not be come in exposure with the light, direct sunlight. It should not come in exposure with the moisture. If these things happen, it can affect the efficacy of the chemical, which is put it for the sterilization. And then it can also impact the microorganisms burden on that equipment. Maintain regular cleaning and disinfection schedule. So in case we have a patient with, let's say, now I think swine flu season is coming or dengue season is coming. So there is a patient in a room with the dengue and next admission is on the way and the person who is already present there is going to discharge. So if in between that patient exchange, there is no cleaning happen, then what will be the outcome of second patient who is just now landed into hospital? What can happen to that second patient if there is no cleaning and disinfection done after discharge of first patient and second patient is taken directly without performing cleaning? What would be the outcomes? Will that patient recover quickly? Cross infection can happen. So yeah, we know there are some microorganisms present from the patient A, and that can be transferred to the patient B who has just came into the hospital setting. Maybe his stay can increased. Maybe the HAI part can take place here. Yeah, it's indirect transmission. So patient will have hospital acquired. Yeah, that could be the case as well. So here there should be a date and time when the cleaning is started. This is very important. If we don't know the time, we don't know what and how long that chemical exposure was given to particular infected area. They need to mention in which area they are cleaning and room number. So there are certain steps with the dilution. So step says the dilution has to be proper. Appropriate PPE has to be used. So PPE, everybody thinks we need to be like a COVID again. PPE is something if any chemical can ingest via air, we need to put on a mask. If any chemical can spill on our hands, we need to put on a gloves. If any chemical spill on our clothes, we need to put on a gown. So then face shield is also recommended with some spray chemicals so that the person can feel safe from the eyes. There should not be any ophthalmic ingestion or any of the spray can go inside and then they can land it into any of other healthcare issues. So there has to be yes and no. If anything additionally is being done, could be written into the remarks. So third objective is classification. Spalding classification help us to identify which cleaning, which disinfection method we need to follow. So this help healthcare practitioners identify the appropriate cleaning and disinfection level for each item. So it start from susceptible, landed up to a resistance. We all know susceptibility pattern and resistant pattern when we sent some patients report for antibiotic sensitivity. So from low level disinfectant, it has certain viruses name. So SARS, COVID, influenza, VRE, MRSA, we commonly saw that's Klebsiella, Pseudomonas. So they need some sort of low level disinfection. And then there are bacteria, fungal spores, hepatitis A, norovirus, mycobacteria, parasitic oocytes. They need high level disinfection. And then bacterias like Clostridium difficile. So they need high level sterilization treatments. I hope you have a little bit idea about disinfection and sterilization and cleaning. I'm just going to talk about quickly. So cleaning is when we just remove the dust particles or the debris from the surface from the equipment. That's normally we do cleaning at our homes. So it's similar to that. But when it involves disinfection, it means there is a EPA approved disinfectant chemical. Sometimes it is according to the infectious organism. Sometimes it's overall cleaning for the hospital surface areas. But in sterilization, so without cleaning, we cannot perform either disinfection or sterilization. We have to undergo the process of cleaning first, and then we can go either ways, disinfection or sterilization, depending upon the need of the equipment. So disinfection involves a chemical agent. It could be done at the low level or the high level. It depends upon ratios. So we might have seen in our ENT OPDs, Sidex, OPA Sidex. So that's a kind of a disinfectant. We might have seen Bactolin. So that's the kind of a disinfectant which is used for high level and low level disinfections. And sterilization, we need and proper equipment where medical items will send for deep thorough cleaning, where there are no spores left and that equipment is safe for use on the next patient. So sterilization, basically what it does, it kills their spores. The microorganism load is also not present and their spores are also killed under high heat temperature. So that's why we always heard about the COVID times. We should not put the patient in the cold temperature. There should be a heat so that that virus cannot survive up to certain temperatures. Ma'am, do you have anything to share about cleaning and disinfection?
I'm making notes of it. Aman, you continue at the end of it, maybe I'll come in. You're doing very well. Thank you. And so I'll come back. I'm making notes, what I can chip in. I don't want to
Sure.
break the flow. Okay. Thank
Okay,
you.
ma'am. Thank you. So moving next, this is very interesting. So we all know this classification, but what comes into classification is very important to know. So there are 3 different categories on which we have divided the devices based upon Spalding classification and what all kind of treatment we have to give according to the equipments. So in patient contact, something that comes in direct contact with the patient. With the intact skin, there are no breaks present, no open cuts or wounds. Like everybody know how to take blood pressure. But did you ever thought of cleaning it every time between every patient so that that chain of infection can break? So it's always be assumed that, okay, I have joined the shift, might be it has cleaned, but it is my duty to break that chain then and there. If I don't know whether it's clean, it's my duty to clean it without neglecting the fact that, okay, maybe my friend has cleaned because she was on the shift. So there is no faith in between if we are working in healthcare setting. It has to be done by me if I am responsible for that particular task for that particular patient. So intact skin, when there are no cuts present, usually we use BP equipments, thermometers, some common shared items. So these comes under non-critical category So here what we can do, we can perform low level or intermediate level disinfection. We all know the alco swab thing. So that we can use for cleaning the tubings part, which go into the airpace and the bell that is used to hear the sounds. So there, that's a kind of example for low level disinfection. So we all know that alco swab is a magic gem. Then second says mucous membrane or non-intact skin. We have ever went to ENT doctor. So he put some tongue depressor, maybe some using disposable ones, but there are people who use the old practice. They put it into a Savlon and don't know what is the date of that change. You might have seen in the clinics, right? So we need to see whether this solution has been made as per the date, or it's been like, I don't know, or maybe whosoever is on the right, they don't know since when this has been like made and since how long it is in a use, whether it is effective or still not in an active stage. So these items comes under semi-critical because they are going into a mucous membrane. So there it can start with the portal of entry and portal of exit both. So here we need high level disinfections. So we need to see whether the disinfectant is actively working. Sometimes solution is being made for, let's say, a month, but the efficacy says it can use up to 15 days. Will that be effective now or it is inactive? So if a solution is made a month ago and the guideline says it can use up to 15 days, can we say it is effective on that equipment or no?
No, not effective.
So why it is not effective, if you can say quickly, Nisha?
Because the guideline says that kit is meant for 15 days. So
Mhm.
1 month is.
Okay, thank you, Nisha. So you might have
Mhm.
seen the argue for budgeting and their stock levels with charge nurses, with the other team leaders. But yes, we need to make them understand what is the need of doing this. So always guide other team members, make things whatever is required. It is not that if I have Sidex 5 liter, I can put directly for one single equipment just for 15 days if my usage is that low. We need, being an ICN, we have to be critical thinker. We need to control the budget part as well. Because if we will not look into budget, then everybody will be like, ICNs are coming and they are increasing up our stock. So we don't want to be into that figure as well. And then third part is sterilize areas of the body vascular system, especially the OT equipments, the equipment that go inside the bodily cavity. So these are very critical equipment. They need sterilization without any second thought. So if anything's used in OT, whether it is minor operation theater or the actual operation theater, it has to undergo the process of cleaning first, manually wash it under water, and then send it for sterilization. You might have noticed you send an equipment for cleaning, for sterilization, but then the cleaning part was not performed. Will they accept? Will CSST department accept without cleaning? I don't think they accept, because if the breakage point is present, still they cannot infect other equipments. We need to break it there. The cleaning has to be done irrespective of anything. So cleaning is not something that you need to start scrubbing the items. It is just washing under running water so that whatever present, blood is present, secretions are present, mucus is present, that has to be removed from the equipment before sending for final level of cleaning or sterilization treatment. So again, this is a checklist. Again, it says critical items, semi-critical item, and non-critical items. So for the critical items, it kills bacteria, virus, organism, and their. So that's the highest level of cleaning and disinfection practice among medical equipments. In semi-critical, it only just kill microorganism and eliminate their spores. So if we say disinfection, still there are spores, but they are in inactive form. They cannot spread infection. In non-critical item, we use low-level disinfectant. It is effectively on most bacteria and some viruses. So here it's not saying it can kill, but it can reduce the burden from that surface. So here is again from our Ontario, the checklist says critical equipment that device enter into sterile tissue or vascular system, something like surgical instrument, implants, biopsy instrument, foot care equipment, eye and dental. So when we go for dental, they use some drilling, some sort of equipment. So that's critical. That has to undergo sterilization process. Semi-critical include respiratory therapy equipment, tonometer, anesthesia equipment. It has to undergo high-level disinfection. Sterilization is recommended, but it is not something that it has to be undergo. It depends upon the need of the equipment. And non-critical equipment is ECG machine, oximeter, bedpan, urinal, commode, chairs, stethoscope, thermometer. Even non-critical equipment could be your pen. We need to clean that as well. Because when we go home, we carry it in a pocket so that organism, multiple, I don't know, I cannot say it's the one organism, it has multiple. So we need to clean that as well. So if anything, you know, other than this, you can just write down in a chat or any doubts you have here so we can talk later on. So these are some EPA approved disinfectant. So when a product can be used, this includes such as countertop, doorknobs, doors, hospital beds, chairs, telephones, and then IV standpoints, connectors, IV pumps, infusion pumps. So these are some high touch surface areas, computer screens. So these products can be used on high touch surface area so that we can break the chain there. So contact time. Contact time is when the product must remain on surface to be effective. So you might have seen we spray something on a surface and leave it for a while. So what is the reason for doing that? Even at home, we clean some, let's say cleaning of the mirror. If you spray and quickly wipe it, will that be effective? Will that help you in cleaning? So it might not be. So we need to provide appropriate contact time as per the manufacturer's guidelines. So there is always a quality check with quality team and ICN. Suppose I am working in a medical surgical unit and I'm new there. I don't know what is the contact time and somebody is observing me. I just sprayed it and quickly wipe it off. Will there be appropriate cleaning done? If I'm not giving contact time, will the surface is effectively clean? Or I will say no, it still have some lackness in cleaning process or practices. So there is not enough cleaning done. It has to be done it as per the steps and protocols. So the surface should be visibly wet for entire contact time. If surface is getting quickly dry, it means the dilution guidelines are not followed. Maybe we are little bit controlling the stock thing, or maybe we are just wanted to finish it off as quickly as possible. So this may mean the product needs to be reapplied. So if I have not given the enough contact time, then I need to perform that task again. So for example, here it says, if the product label has a contact time for 10 minutes for a particular pathogen, the surface should be remain visibly wet for at least 10 minutes after the application of a product. If after 5 minutes the surface is not visibly wet, then need to apply more product so that there is enough contact time as per the recommended guidelines. So products can be liquid, spray, powder, or wipes. The product should be used or applied according to the directions of use. So here is a quick ask. Are we going from less contaminated to more contaminated while cleaning, or coming from more contaminated to less contaminated? So what does cleaning principle says? Less contaminated to more or more contaminated to less while performing? Why does we do that? Why cannot we start from more contaminated to less contaminated? Why don't we take it as a more contaminated on priority and less contaminated on like least priority? It will spread to less contaminated area. Okay. Will you be able to identify if I start from more contaminated and then coming back to less contaminated, which one was the least important and which one was the most important? Yeah, more is already infected more. So then we spread more. Yes, of course. That's true. If I am starting from more contaminated and I'm making less contaminated as a more contaminated, then there is no difference. So always remember, go from lesser to higher number. But in HAIs, our target should be 0 to achieve 0. I know it's not 0, but we have to like try our best so that we can reduce the burden of HAIs. So this is very interesting part of the presentation, use of appropriate PPE. So I'm gonna quickly ask you questions and then you can reply on chat box. So if a healthcare worker or housekeeping person is asked to clean patient bed, so what all PPE items are required to clean the bed? What will you recommend to a housekeeping person while cleaning the bed? What all PPE item he or she should wear? Gloves and gown, heavy duty gloves, mask. Okay. 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 So if he or she is cleaning high touch surface areas, what do you recommend? Gloves, plastic apron, all PPE, full set of PPE, heavy duty gloves, all PPE. All right. So yeah, there are some different practices where we need appropriate PPE. It depends upon the need of the chemical. So PPE include gloves, gown, mask, face shield, goggles, or shoe cover. Shoe cover is always optional, except the area where there is a exposure or where we can suspect an exposure or outbreak. So PPEs are the devices made for safety of healthcare workers while handling disinfecting agents. So our aim is to prevent potential chemical exposure, splash, and accidental spills. So when there is a spill, have you seen housekeeping is wearing full PPE, starting from cap till the shoe cover? Why do they do that during the spill? Why they wear full PPE? We should wear all sets. Okay. But during spill, why it is recommended that it should cover from head to till foot section, like shoe cover has to be wear? Because most of the time spills are unreportable. They are just under the covers. So if there is a spill, somebody vomit out, somebody has a blood cut and have massive blood loss, like in a delivery room. So there are chances that spill can contaminate the whole surface area through the shoes. So if there is a spill, that should be contained in a one containment zone. If it is like everybody's passing through that spill, there are more chances that it can spread to one department to another, and then it can spread all over the hospital setting. Sometime being an ICN or link nurses, you might have noticed there are times infection rates are high, but the cause is unknown. Then we need to check with housekeeping team how they are operating, how we are operating, how our nurses are operating, how CSST department is operating. So then by doing this much surveillance, we came to know that there was a loophole we need to close. There was a lack in practice. We need to keep a check on it. So PP, it's always on priority. Donning, doffing has to be known. How to remove gloves. Sometimes they just take it out. It's like this. Sometimes they just start playing. So there, the splashes can go on the surface and it can again multiply the microorganisms there. So we need to train everyone how to wear it properly and how to safely dispose it off. So the second part, we're going to start with environmental hygiene. Earlier it was equipments, but now we're going to talk about environmental hygiene in preventing antimicrobial resistance. So here, the objective says understanding the role of environmental hygiene in reducing antimicrobial resistance, identify primary microorganism and practices to reduce antimicrobial resistance. So primary type of microorganism. Anybody know any microorganism who is their friend? Anybody know any microorganism name? You want to write it down in a chat or you just want to say it? Any microorganism, you know, any CRAB. Okay. Candida, MRSA, pneumonia, Klebsiella, Pseudomonas, E. coli, VRE, Staphylococcus, Acinetobacter, Staph aureus. Okay. So I can see pretty much good examples here. Thank you for your response. So microorganism, what they will do, they always increase the risk of transmission of disease, severely make the person sick. It can land up to disability as well or mortality. So mortality and morbidities are two terms that are quite familiar with the EMRD department, where they can keep a track how much sickness rate is in our hospital or healthcare setting, or how much death rate is occurring due to hospital acquired infections. So if I'm gonna quickly review with the primary type of microorganism, we always notice that there are some bacteria, virus, fungus, algae, protozoa, archaea. So bacteria are some goods or some bads. So good bacteria we have in our intestine, bad once it come outside from the body, it's bad for the environmental surface. So if I have E. coli inside my intestine, will it be good or bad? If it is still in my intestine, will it be good for me or bad for me? So it is good bacteria for me if it is inside my body. Once it is coming out through the stool and starts spreading infection among other workers, other patients, its state change from good to bad. Same with the virus. So we all know different viruses, but three are the main: hepatitis B, hepatitis C, and HIV. Need to very cautious when dealing with these kind of viruses. So virus, bacteria, these two are the main important microorganism. Sometimes protozoa, algae, or fungus can happen. So fungus we can see when there is a excess moisture, when there is more water loss or more water deposition on a surface. And summer stays on the environmental surface for a longer time period. We cannot see them with the naked eyes. Can we see microorganisms? We cannot see. So it's always seen under microscope. What if we enter into hospital and we have some special glasses where we can see? Will we be happy to enter into hospital? If we have that some magical glasses where we can see, okay, now E. coli is going with me, Klebsiella is going with me. I don't think anybody can go inside if they will able to see microorganisms. This picture is horrifying. So it says either ways. It's coming out as well, and it's going in as well. So if we are giving something good to the hospital, we will always take it as a good thing back to ourselves. If I am going with an infection, will I be doing a good thing? If I am coughing all around the patients, am I giving them something good? I don't think so. It's like I'm spreading. I am just acting as a mode of transmission between the patients, between my healthcare workers at the hospital environment. So hospital environments as breeding grounds. Any auditor comes, they always say, yeah, this cleaning is not done properly. So I can see there are some reports says that there are infection rates was high and then suddenly dropped down. So anything cannot be happened suddenly. It takes certain times. Like for a HAI to develop a hospital acquired infection or healthcare associated infection, it take up to 48 hours. So if a surface has not been cleaned more than 48 hours, then that surface could be a reservoir. That surface could be a mode of transmission to promote that infectious rates. So constant influx of patient, we might have seen our hospitals are always busy. Patients are coming. They are coming with different infections. They are coming with different microorganisms. So then from there, it spread variety of pathogens. Somebody came in emergency with cough. Another patient came in emergency with pneumonias. Another patient came with an open wound injury. So there are 3 different case scenarios and 3 different organisms. If a healthcare worker does not perform appropriate cleaning, then that open wound can get something like called post-surgery surgical site infection. That pneumonia patient can catch pneumonia if he or she can take into ICU. So we need to see what is the pattern, what is the demand, what is the requirement. So why then if I caught pneumonia inside the healthcare setting, doctor will recommend me antibiotic. So we all know, we all are self-doctors. If we catch a cold, let's take amoxiclav. Let's take this medicine. Let's take that medicine. So that's how the misuse starting. So if there is a widespread of antibiotics, there are incorrect use of disinfectant, which leads to drug resistance. So here I'm just trying to correlate with how does a disinfectant can reduce antimicrobial resistance. Suppose if I'm not cleaning stethoscope, so that is spreading from one to patient A to patient B to patient C. So that chain is not getting break at any point. But yes, if I'm cleaning the stethoscope after every patient use, after every dedicated time frame, so their chain can be break, right? So we need to see how that disinfectant can help us to breaking the chain, how that disinfectant can help us to reducing the microbial load, how we can safely use antimicrobial agents, because they are not meant for regular use. They has to be used for particular infection, for particular patient, for particular reservoir. So we need to see there should not be drug resistance. So what will happen if a patient develop drug resistance? Will we be able to use any other drugs? Suppose if a patient is resistant to vancomycin, can we give vancomycin again? No, we cannot give. Why we cannot give? Because that already has placed so many multiple colonies that that person is resistance. It is not gonna give any effect. It's not gonna kill any infection, any organism present inside that patient. So what if a housekeeping person killed it at on the surface, and that patient has not to go under any antibiotic therapy for that such hospital or healthcare associated infection? So then we can recover the morbidity and mortality standards as well, right? So antimicrobial resistance says it has significant threat to public health, increasing morbidity and mortality rate, and increase in healthcare cost. So the picture says sorry, but no amount of antibiotics will get rid you for your cold. Has anybody have taken any medicine, any antibiotic, particularly for cold, ever? Doctor recommended you for common cold that you can take amoxiclav or you can take azithromycin. Ever? Have you ever given just for cold? I'm not saying for sore throat or any other bodily inflammation. Push by saying no. I assume rest everybody have taken. Because I have seen there is a practice that doctor says, okay, let me reduce my burden, take amoxiclav or take azithromycin if you have only cold. So cold, we all know it's just a seasonal infection or it's like inbuilt immunity. So there is no medicine so far we can take for cold. Yeah, it's common drug nowadays. It is. So as like this, one day, vancomycin will be selling like as a common drug if we will not stop antimicrobial resistance at our end. So how we can stop? With ensuring environmental cleaning, with equipments cleaning. So if you ever recommended by a doctor take azithromycin just for a cold, always try to figure it out the reason. Because if one medicine you are taking for now, then your brain will say next time you catch cold or I catch cold, I will say, okay, I know what I need to do. I will simply take antibiotic. And then I'm building up the resistance. I'm building up some sort of wall against an effect. So once the wall is made, it's very hard to break that wall. So here are some data from India 2019. Antimicrobial resistant burden in India. In India in 2019, there were 297,000 deaths attributed to antimicrobial resistance. So it's not only I'm saying from one drug, it is from multiple drug usage. And 1,42,500 deaths associated with antimicrobial resistance. So we can see the global burden. We can see the burden in India for antimicrobial use. So this data is from 2019, almost 4-5 years back. So just imagine the number, how much the number has gone up with these deaths. So we need to be very cautious when we are studying cultural reports, when we are looking into patient scenarios. So India has attained 60th highest age standardized mortality rate as per 100,000 population associated antimicrobial resistance across 204 countries. So I don't think this is a proud moment for us. 60th rank is like how near we are in terms of promoting this resistance. So the number of antimicrobial resistant deaths in India is higher due to deaths from neoplasm, respiratory infections, tuberculosis, enteric infection, diabetes, and kidney disease, and maternal and neonatal disorders. So these are some infections we always see in our day-to-day practice scenario, in gynae ward, in neonatal ward, in dialysis or kidney transplant units, in GI ICUs, in respiratory clinics, in respiratory ICUs, and then in cancer units as well. So these are some common data taken out from pathogens. E. coli is on the top, then followed by Klebsiella, Staphylococcus aureus, Acinetobacter baumannii, and Mycobacterium tuberculosis. So we need to see the figures in detail. So this data has to be shared with people who are working on the floors. It should not be contained to the ICNs or it should not be contained to the doctors. So they know how does that E. coli spread from one patient to entire hospital, how this Klebsiella pneumonia spread from one patient to entire patients. So we need to understand that connection. We need to understand that link between those surfaces, equipments, and these antibiotic resistance. Okay, so that's the favorite part of everybody when they are on rounds, hand hygiene practices. So what do you understand with the term hand hygiene? What comes when you see or when you heard something like hand hygiene? What clicks into your mind? Just you are free to write down your thoughts, anything you want to write about hand hygiene. I'm gonna end it quickly soon if you guys got bored. Okay, prevent cross infection. What else you understand from term hand hygiene? Okay, 70% reduce HAIs. First and foremost important thing, that's good. Yeah, everyone talk but hardly done. That's true. Cornerstone for preventing infection. Yeah. So pretty much good answers. Thank you for participation. So hand hygiene practices basically involved how to do it and who has to do it. So everybody think it's my job to teach, but nobody take that responsibility to actually perform, actually give them a demonstration. That actual thing, that action has to be taken as well. It's not just always about talking, it's always about performing, doing some actions. So hand hygiene is done by two methodologies. One is using soap and water. We all know COVID has taught us very well what does this hand hygiene mean. So using soap and water, follow the steps, WHO steps, and using alcohol-based hand rub, using again WHO steps we need to follow. The only difference is some organisms are effective with soap and water, some are effective with alcohol-based hand rubs. So if a patient have MRSA, what will you do? Using soap and water or using alcohol-based hand rub? Patient with MRSA. Chandraprabha says soap and water. Soap and water, okay. And if a patient is having E. coli, what will you do? If a patient is having E. coli, will we use soap and water or alcohol-based hand rub? Soap and water, alcohol-based hand rub. Okay, so this I will take in the end. Surface cleaning and disinfection chemistries, use of right cleaning and disinfecting agents, selection of appropriate cleaners and disinfectant for specific pathogens. Again, the stress is given on disinfection agents and the type of microorganism we want to treat. So this has to be understood. I cannot use MRSA effective disinfectant on Acinetobacter. I cannot use Acinetobacter. Particularly, I am saying there are disinfectants that are active on all type of microorganism, and there are disinfectant that need specific type of organism and specific type of disinfectant for the cleaning. So we need to understand the relationship between type of organism and type of disinfectant particularly used to kill that organism. So there are some advanced adjunct techniques. After cleaning, we can use any of these methods: hand spray and wipe, electronic sprayers, electrostatic sprayers, and UV rays. So these are some advanced technologies that has introduced into the disinfection practices. So antibiotic stewardship program says stop antibiotic resistance now. So how we can do that? Protective the effectiveness of antibiotics is a collective effort that require community awareness and support. So we need to protect our community and know the facts. If I have infection, I need to see what kind of infection rate it is. I need to go and talk to my doctor. In a community setting, being a healthcare worker, being a community healthcare worker, we need to create awareness. Maybe you have noticed nowadays this antibiotic things coming through the food supplements. So the foods are not normally grown in an appropriate environment. They are injected some antibiotics, some sort of chemicals in them. So we need to educate people. It's not to scare them, but just to aware them. If you ever came across anything, or if there is a person who need medical assistance, just refer them to primary healthcare center so that we can resist timely intervene into the community where it require immediate attention. So we should take that responsibility at our end. We need to educate, we need to create awareness. So this is something which is hidden from population, hidden from people. A doctor is recommending antibiotic, but at times there are some reasons which are hidden behind. So patient education is also an important part in reducing microbial resistance. Environmental monitoring and surveillance. Suppose a cleaning is done, but nobody is checking. Will I say it is okay? Will I say it's good to go? If there is no a counter check is performed. Are we safe then? I think we need to recheck it. We need to see. We need to monitor. We need to actually look into the practices which are performed by the cleaning team. You have anything to say about monitoring and surveillance? You might have seen ICNs are coming on round, our charge nurses are after us, why we are not looking into when housekeeping is cleaning or when we are cleaning, whether it's done from less contaminated to more contaminated, whether the principles are followed, the dilutions are checked before cleaning, solution is being freshly made, or the clothing which is used for cleaning, it is clean and it does not have any other debris, any other dead thing present on it, or any other leftover of from the previous cleaning shift present. So are we checking all these things? Okay, it's mandatory. Checklist and thorough monitoring. Okay. Yes, that's good if it is done. So it is very important. We need to see. Everybody know how to do their job, but it is as important they know to check them. Where there is a lack, where there is a gap, we need to fill it out. So here are some references from where the content is referred. And thank you so much for listening me. I found it very enjoyable. And
We
thank
also
you.
found it very, very educative, and like the way that very calmly you took through many, many important aspects of it. And this topic we chose is only because this is one area, uh, all said and done, does not get its due attention because we are too busy with many other things. So I really hope all the people who attended today and all the people who are going to watch this video would continue to focus on this, because when I do the ICN program, this is one thing that keep on insisting. It is not about telling that it is housekeeping job. Yes, it could be housekeeping job. It is equally important for ICN to go and check what is their training schedule, what is their own checklist. You can just check once in a while that whether the checklist is the right thing, whether it is top to bottom, or less clean to more clean to dirty. What is it that they are doing? Maybe we know everything, but we are not sure, because all the boys and girls who come in housekeeping, they probably are trained in hotels, not in hospitals. So hotels are okay, but in hospital, every technique is important. So I have a couple of things to ask you. That's all. Because if I may ask about the dressing trolley, there was a mention about the dressing trolley. So I would like to know, please answer about MRSA E. coli. What didn't understand. Um,
This
What?
was like between MRSA, we should go for hand washing or alcohol-based hand soap.
Okay, okay. The hand hygiene, see, the hand hygiene, the word hand hygiene involves either hand washing with soap and water or hand rub. There is one very basic, understanding is that if your hand is dirty, always use soap and water. If it is not visibly dirty, you can use hand rub. The exception is C. difficile, where you cannot use the hand rub, you must use always soap and water. So that's the only thing that one need to keep in mind, whether it is MRSA and E. coli, the hand hygiene technique are not changing. It remains the same. If your hand is soiled, wash. If the hand is visibly not soiled, you can use the hand rub. But what is more important is that how are you washing your hand and how are you using the hand rub? Because that itself is a important discussion that whether you are using the adequate volume, are you using the correct duration, are you using enough friction. This is very important because everywhere it is scrub, rub, scrub, rub, scrub, rub. So even when you're doing the hand hygiene, it has to be scrub, rub. So very quick question. I know it's 8:11, so I will wrap it up in another 2-3 minutes time. I just want all of you to think about how is your dressing trolley looking like in the hospital? Is it overstocked, or is there a place that is empty on top for the people to open the sets after disinfecting the surface of the trolley? So in Indian hospitals, even from where I come from, the initial thought was to put everything into the dressing trolley, whatever you may need anytime. So overstocking of the dressing trolley and then empty space is required. Yes, it is good to know those things are changing because um, it took a while for when I was in Fortis to even discuss about it because everybody wanted everything in the trolley. And then what happens is then the dressing sets are opened on the patient's bed in between the patient's thigh. And believe me, ladies and gentlemen, I have seen this happen in the best of hospital when one of my relative was operated, you know. So the dressing set was opened on the bed in between the thighs. So there are thousands of opportunity for the organism to spread. We are thinking we are supposed to break the chain of infection, but we are not doing enough. And their cleaning and disinfection. So important to provide the right resources and the right guidance. So another thing that comes to my mind is stethoscope is a challenge. And Haman did mention that after every touch, you have to disinfect the diaphragm of the stethoscope. Good. So when you have such issues, now many ICUs have gone for individual stethoscopes for each ICU bed. This is one way of engineering to ensure that some transmission is, kind of stopped with the patient only. So thanks, Aman. You went into a lot of basic stuff, but I think these are very, very important. And I just have one question. This thing I wrote here, when you're using Sidex, when you're using OPA Sidex, I know many hospitals have reduced the number of places where Sidex is stocked in the hospital. So let's say there is Sidex in one ICU and somebody comes and puts a stethoscope for, for your high level disinfection. So how many minutes does it take? Let me ask the audience sitting here. OPA Sidex, how many minutes for the stethoscope? Can we have some answers? There are still very serious people sitting here. So 6 minutes contact time. Okay. 6 minutes, 2 to 3 minutes, 20 minutes. Now that's a whole range of duration. There is a problem there. So one thing that I would like all of you to take away is that please read the product. What product you are using and what is the recommendation written on the product, how it should be diluted. and how long it can be kept, and what is the contact time. So 20 minutes for all items. As far as I know, what I have practiced, 15 to 20 minutes is what. But I have one question. So let's say that you put a what you call a laryngoscope at 8 p.m. into the OPA. So you can take it out at 8:15 or 8:20. Okay. So one item is already there in the OPA. At about 8:10, before you have taken the previous, laryngoscope, somebody else comes and puts another laryngoscope for disinfection. So my question is, can you take the first one out at 8:20? Good. Already got the answer no, because while the first process was going on, you put another contaminated item. It's clean, but it's not yet sterile. So both of them will start the time with the second one. So these things may be known to the ICNs, might not be known to all the nurses. So it is very important to keep a watch on that thing. So another important thing Aman mentioned was about the contact time. It's a very basic principle for everything. There is a contact time for alcohol. There is a contact time for chlorhexidine. There is contact time for betadine. For all of them, they have contact time, because if you don't have that contact time, then it will not do its intended work of protecting the surface, whether it is skin, body, or it is a table or a bed, it doesn't matter. So it is important to understand. So it's very interesting when you actually deep dive into housekeeping and you see all the gaps. I did that when I was preparing the hospital for NABH. So I really had to get into every single department. So when I got in there, then I realized, that there are gaps. And then I had to read their policy manual to see what is their protocol. How does it say? I have shared some documents which I could find in the chat box. I hope you people have downloaded it. Could be of use, because you may like to have such checklists in your hospitals as well. So thank you, Aman, for speaking to all of us from Canada, and wish you all the very best to do well in Canada. You took the session very well and calmly. Thank you so much. And God bless you and keep shining. That's what I can do. And thank you, everybody, for joining us and staying with us. And if anybody has any comments or anything, you just can take 1 or 2 minutes. Otherwise, we'll see you all on Monday to discuss SCLAPSI. So thank you, everyone. Looks like all are happy with what you have shared with them. And this is one topic I would always request ICN, keep reading, keep knowing more. That's the only way you can become the patient safety champion. When you know only, you will know where to go and check what. So I hope this was a bit of an eye-opener for all of us to learn more, do more, and protect our patients more. Thank you, Aman. Thank you very much. And thank you to all the audience here. Good night and good morning, Aman.
Thank you so much, ma'am.
The day just
Have a
started.
good
Thank
night
you
to
very much.
everyone. Enjoy
Bye-bye.
your weekend. Bye-bye.
Thank you. And happy Diwali to all of you next week.
They will come on Monday for Diwali.
Okay. Then next week, Monday is Dhanteras, I think. Okay, happy Dhanteras. Take care.
Thank you so
Bye-bye.
much, everyone.